So back in April, we did a segment on red eye before the interns got here, and we covered a lot of anterior segment stuff and then a lot of anatomy. And I'm not going to do any of that today. We're going to talk about posterior segment stuff. We're going to do some neuro-ophthalmology. And I don't know how we're going to make our little videos work, unless maybe I stop the video. Maybe that would be better. But anyway, we'll see. Let's see if maybe we'll see the next one if I stop the video, if that works. Okay, so anyway, so the first thing I'd say is we're all going to be taking in-service exams, concert exams, although that's changing, but there are a few pictures on the screen here. Most of the senior residents should know exactly what these things are, because they will appear on your boards, and it's just free points. Okay, I mean, it's just like, you know, it's just instant recognition. So if you don't know what these things are, then pay attention, because we're going to go through pretty much most or all of these things today. So we're going to do this case base, and your waiting room is filling up with patients, so you better get to work. So we got the first patient here, and she's a 24-year-old female. She has 4 months of global headaches, 4 months. She's had 2 visits to the family doc. She's had 2 visits to urgent care. She got a CAT scan outpatient. She tells you that was normal, and she complains of visual blurring and triage, and her vital signs are normal. She's in a fair amount of pain. She's 20/70 in the acuity department in both eyes, as well as each eye individually, but she didn't bring her glasses. In her physical exam, she's an overweight female, so there's a clue. She appears very uncomfortable, and of course you did, because it's a headache, a good ENT exam, a good dentition exam. You looked at her neck, and there's nothing there to write home about, and her neuro exam is, of course, normal, as most of these people. You know, we're not talking headache and a stroke here. We're talking just a headache, a febrile headache. Hello, doctor. Hello, patient. And that's really the whole damn neuro exam. You don't get any more information over the next 15 minutes. She has no meningismus, as if I've ever found that helpful in 30 years, except in the moribund. There's no mass in the neck, no adenopathy, and pretty much she has a normal pupillary exam, normal ocular exam up front. So, you know, what's the differential diagnosis for this lady? I kind of put a short list together. Now, y'all might have some other things to consider. Mass lesion, because the CT isn't so sensitive to pick up a subtle mass. Migraine, well, she's in the right age group to develop migraine, but that's a diagnosis of exclusion. Tension, same thing. Idiopathic intracranial hypertension. This history, and the reason why I kind of, you know, invented this history this way, this is pretty classic. These people, every time I've diagnosed one of these people, they've been to 3 or 4 other providers before they see you in the ED. And so, you know, the guy in the office can't make this diagnosis necessarily. Sometimes I won't even think of it. And a lot of these people will come in with history of, I just got diagnosed with migraines by my family doctor and started Furisate. I put carbon monoxide on the list because you wouldn't necessarily think that, you know, 4 months of headache is CO, except if the doctor doesn't consider it, including us, we send the patient right back home to the leaky furnace. And so this can present in a subacute way, and there's probably other stuff, but I didn't think of it. So anyway, what did I not give you? I didn't give you one piece of the pie, and that is I didn't do any kind of a retinal assessment. And I didn't give you that. And of course, you were all thinking, well, he didn't examine a retina, we're in eye talk here. What's the story? But I got to tell you, if you are evaluating a patient with a headache, and it's likely that in the next 12 hours you'll all do that, and you don't do a retinal assessment, don't bring that to me, because it's an incomplete workup. Every community ED doc that I've ever worked with from the 1990s on knew to do this, and somehow we've sort of lost our ability to do this. I chuckle every time neuro writes a consult and they say consult ophthalmology to rule out papilledema. Don't they do that? Don't we do that? So, you know, I think the more of these things you do, the better you get at it. But there are 5 ways I can think of to evaluate a retina. Okay, the first thing is color vision is a retinal function, so you can actually show a patient the same object and have them look at it with the same, with each eye individually, and see if they think the saturation is the same. So there's my balloons up front. The one on the right's not as saturated. Visual fields, you got to test that with each eye. It's very insensitive, but man, is it hugely specific. Afferent pupillary defect, that ought to be there. You should do a fundoscopic exam, and in this day and age, I would say that your ultrasound is probably the thing with the most sensitivity to pick up some of this pathology. So our slides are not moving. There we go. If you're an ophthalmologist and you do indirect fundoscopy with the scleral indentation, you can see 100% of a retina. We can never do that. We can get to 85%, and that's if we dilate them. And of course, we dilate nobody at Rhode Island Hospital because, of course, we have an ophthalmologist right in the building. But that's something you probably ought to consider doing if you're out in the community. Okay, you want as good a look as you can. If you don't, you're struggling and you can see 15% of the retina. Now, of course, this is what I see in most of the rooms around the place. And if you don't look at all, you see 0%. So the issue is that you can't get good at these things without practicing them. And you don't need to know the path necessarily. I mean, I stumbled into a toxoplasmosis about 2 years ago, and I had no idea what I was looking at. Funny, the opto resident didn't know what they were looking at, but everybody agreed something was wrong, and the patient ultimately had toxo. So I think the more of these things you'll look at, the better. So my question is, which one of these patients has papilledema? Okay, which one of these photographs looks like papilledema? The answer, it's a trick question. They all have papilledema. Okay, it's just different grades of papilledema, right? So what do I usually tell you guys in the department? That's normal. That's normal. And what makes it normal is this. The figure skaters skate when she floats through the ice, okay, and that ice was just cleaned by the Zamboni. There's that razor sharp line, and that's what that edge ought to look like. So if it doesn't, there's an issue. Now, some people will have a little blunting on the medial side. Again, you know, you look at all these things, you listen to 1,000 hearts, and all of a sudden, this one doesn't sound right. Okay, so of course she had papilledema on exam. She got the obligatory repeat CT, which was negative. And of course we do an opening pressure. And Joe Moran and I had one the other day that was 52. This one turned out to be 38. So, you know, this is a no-miss cause of headache for you and I. Now, I don't know that you're going to necessarily have to tap the patient. A lot of these people are hugely obese, and it may be a difficult tap. And, you know, I'm of the opinion that if you got to use that 7-inch, the quote, harpoon, then maybe you ought to send that patient to VIR if you can get it done. But, you know, you give it a try, right? But sometimes you just can't get the thing because you just can't figure out even where middle is. But it's an important thing to get. And I would say you should be doing an opening pressure on every LP you do, because this diagnosis has surprised me in the past. I'll get to that in a minute. So basically your path is venous pressure is elevated, which causes decreased absorption of CSF by the arachnoid granulations. And then CSF pressure goes up and you get optic nerve atrophy, but this is a very slow process, usually not always. Sorry, you won't find a thing on your CT scan, okay? The upper limit of opening pressure should be 25, but most people are going to be under 20. There's a female predominance unless you're a child. Now, that's an interesting thing. It is, the old literature would say that a lot of this stuff in children are related to things like complicated otitis media, mastoiditis, etc. And so there may have been a more equal predominance of boys and girls. But in the adult population, this is mostly women. They are frequently overweight, and there are several medications which have been implicated as potential causes of this. Tetracyclines, quinolones, you can read the list there, lithium, contraception, etc. There's also a loose association with obstructive sleep apnea and some autoimmune diseases. I'm not sure if the OSA is just a confounder because a lot of the overweight crowd has OSA. Headaches often worse in the morning. They can be reported as pretty much any type of a headache, retrobulbar, temporal, hemicranial, occipital. It's all there in the literature. Any headache, especially people with, quote, a new migraine diagnosis that, you know, haven't been seen by a neurologist. You know, my family practitioner, internist, pediatrician just told me I have migraines, or my mother. You know, you got to watch that word migraine. Patients will use that word to mean a bad headache. It's not a headache, doctor, it's a migraine. Well, how are you using that term? I know what I mean. You know, when I say migraine, what do they mean when they say migraine? Migraine's a specific thing to us, but to the patients, not so much. I have seen this come in as a thunderclap headache. I had a lady that, crazy story, you know, I love telling stories, very briefly, at the Miriam about 7-8 years ago, that came in. Her sister had a berry aneurysm, and the day before, she'd gone to another emergency department in the state, not Rhode Island, not one of ours, with a with this headache, and She didn't get even a CT. And I'm thinking, what kind of a moron wouldn't even do a CT for this patient? You know, her sister had a freaking bleed, right? But then she tells me the headache's been, you know, almost every day for 3 months, and you realize there's no way this is subarachnoid bleed. So I send her for a CT, she comes back, and then she gives me the question, that'll definitely show it if I have a bleed or an aneurysm, right, doctor? And of course, I got to bite my tongue because she's had this headache for weeks, and I'm thinking, well, the sensitivity's not that great. And then we get into this discussion, she wants me to LP her. I'm like, you got to be kidding. So I tell her all about the, you know, the fact I've done 2 of these in my career, and the, you know, the first person was crippled forever, and she still wants me to tap her. So I tap her, okay? And I must have got an opening pressure like 40 or 50, and I'm like, wow, that never even entered into my differential. Okay, so I do a therapeutic LP, and she's better, and she thanks me. And I'm thinking, wow, that shouldn't have been a thunderclap headache, but it was. Patients who have worsening headache or transient vision loss with Valsalva, very specific piece of history, okay? The patient develops an insidious field cut with enlarging blind spot. So a lot of times they're unaware of it, and so they can be really lackadaisical about their follow-up. They can present as blurring, scotoma, transient visual loss, what you might consider amaurosis. They can present like that and get better. Diplopia, cranial nerve 6 is most at risk with intracranial hypertension. That's been on every exam since medical school and probably will be forevermore. They can have photopsia, which is bolts of light, photophobia, dizziness, nausea, other cranial nerve deficits less likely, and tinnitus. The visual acuity is very insensitive because the macula is usually the last thing to fail. And in one study, only 1 in 5 patients with intracranial hypertension had Snellen chart detected visual issues. In another, in I think the same study, this was a review paper I read, but you know, 1 in 3 had a demonstrated field cut on exam, but 92% when the ophthalmologist did perimetry had a field cut. So that confrontation exam is very insensitive, but pretty specific if you find it. Papilledema can be bilateral, usually, but maybe transient, so be careful. Imaging, as I said, insensitive, slit-like ventricles and 11% optic nerve sheath enlargement right. I'm going to pick that up. Good luck, Bob Tubbs. Consider CTV or MRV if you think maybe this patient could have a dural vein thrombosis of some sort, in which case it would not be idiopathic. And the visual loss in some cases can be precipitous, which is usually related to the degree of papilledema. So usually this is not an emergency. If this patient's lost their visual fields acutely and has massive papilledema, that's probably an emergency, needs to be LP'd, optho, neuro, maybe neurosurgery, and you're going to start Diamox. So your next case, this actually happened to me at Kent, 31-year-old female who is working with me on a 4 to 12 shift, tells me she's been at the beach all day and has eye pain. Dr. G, would you mind just looking in my eye? You know, a little curbside consult kind of thing. I look at the eye, I don't see Jack Diddley with it. I tell her to go back to work, you know, I need that UA done, She keeps bothering me every 10, 15 minutes, you know, and like halfway through the shift, she tells me she can't see out of the eye. Okay, she has no previous history, and I'm like, okay, fine. So it must be a corneal abrasion, right? She spent the whole day at the beach, of course, corneal abrasion. So I'm busy, so, you know, I pilfer a little bottle of tetracaine, you know, get it from the charge nurse. I drop a few drops in. 10 minutes later, I'm no better. 10 minutes later, I drop more tetracaine. Like, you know, after an hour, I dump like the entire bottle in, and she's still no better. She has eye pain, and she's visual loss. Okay, what's my differential now? Okay, well, you know, she has glaucoma. The eye isn't red. She could have optic neuritis, I suppose, uveitis, but she's got no weird, you know, rheumatologic history. She doesn't wear contact lenses, scleritis. We covered this in the first lecture back in April. Corneal abrasion, which is what I think she's got. You know, she's at the beach, maybe the sand blew in her eye or whatever. She's afebrile. She's got terrible acuity, okay, out of that one eye. So, you know, I do an anterior segment exam, you know, a quick thing on the bedside with the, you know, scope. I don't see a damn thing wrong with this eye, okay. Slit lamper, you know, she's got nothing. Fluoresceiner, I don't see any corneal abrasion. So what's the most likely diagnosis for burned out ED nurse with visual pain and eye loss? You know, she's malingering and she wants to get out of shift, right? She just wants to get out of shift, right? What's the missing piece, of course? Oh, wow, look, the video played. Damn, we missed 007. She had an afferent pupillary defect. Again, this is one of those 5 ways to evaluate a retina or an optic nerve, right? So as you can see there, the right eye dilates to a direct response. Okay, it ought to be equal in both eyes. So that right eye is dilating in response to the light being shined directly at it. So she had an APD, and what does she have on fundoscopic? You know, it's funny. The first time I saw papilledema in the community, I didn't believe it. I assumed it was my ability, my lack of ability to use this ophthalmoscope, right? Just like all you say to me, oh, I'm not very good at that. You know, I'm a new attending. I'm at Marlborough Hospital. It's the middle of the night. Similar kind of thing. Woman comes in with eye pain. I have no idea. Whole bottle of tetracaine. And she's got this. And I'm like, that's not right. It must be me in the scope. So I examine the nurse as a control in the room. Okay, then examine the patient, examine the nurse, examine the patient, examine the nurse. The woman's husband's looking at me like, doctor, should we go somewhere else, you know? And then I decide she's papilledema, she's optic neuritis. True story. Strong association with multiple sclerosis, up to 3/4 of them in some patients. The vision loss, fortunately, is usually transient. So while they have a good visual prognosis, even though it may take years for them to improve, overall, their neuroprognosis may not be so good. It is not synonymous with MS. Okay, in these parts, you think Lyme disease, there are viral infections like HIV can do it, TB, toxosyphilis. So it's not slam dunk, it's MS. And remember that if the inflammation is on the optic nerve, but behind the optic head, you won't see a thing. That's retrobulbar neuritis. And the old adage there is the patient sees nothing, the doctor sees nothing. So she gets an MRI, she's demyelinating lesions, and she said, ain't no way, Dr. G, I'm letting you tap me to look for oligoconal bands. Third case, this is a true story, another one, Kent Hospital, 78-year-old female, chief complaint of complete visual loss the night before while watching television. In the morning, she's no better. I see her at 10 in the morning like a Tuesday. All right, she had an MI, she has a little mild cognitive decline. I think, well, maybe she shot an embolus, you know, could she be an AFib? She, EKG though, she's sinus rhythm, she's got an old anterior wall MI. I think could be temporal arteritis, giant cell arteritis. I sent a SED rate, that's negative. She's got pretty good acuity overall. Anterior slit lamp is normal. I don't find jack diddly wrong with this eye. Okay, but of course my differential for you know, acute painless loss of vision would be central retinal artery occlusion or branch occlusion. In this patient, she's an old woman, giant cell arteritis, central retinal vein occlusion, retrobulbar neuritis that we just talked about, retinal detachment or vitreous hemorrhage. But I examine this woman, right, and I expect that I'm going to see this on the right. There's one of those pictures. That's a central retinal artery occlusion with a classic cherry red spot because the macula is firmly adhered to that retina, and as that retina gets edematous, it pulls away, it gets edematous, and what you see there is the macula just sitting there attached to cherry red spot. And on the right side there is the blood and thunder retina of a central retinal vein occlusion. Now, in the last 2 months, I've seen both of these with a scope, and I've seen both of these with a scope, and I've actually discovered a retinal detachment with a scope and with an ultrasound. So you can actually see these things if you look, and it's fun. And your opto consultant will piss in their pants laughing so hard that you made a diagnosis like that. So great news. Well, I examine this woman. What do I see? A normal fundus. So not being very smart, I'm thinking, I don't see jack diddly wrong with this eye. Here I am at Kent Hospital Tuesday morning. Right across the street, though, is Koch Eye. All right, so I call up Koch Eye. I say, hey, ophthalmologist, yeah, listen, I've got $150 here at the ER. Would you like it? Can I send this patient right over to your office? So they say, sure, send the patient over to the office. So I do that, and about 20 minutes later, they send her back. And I'm like, what? And they send her with this note, okay? True story, I'm not kidding you, okay? This woman, they say occipital stroke, admit and consult neuro. Like, what am I? I must be a moron, right? Be very careful with this history. I've seen not just me, but other physicians below this. Be aware of the patient who claims that they've lost vision in one eye, okay? Because it could still be one field, okay? And this was an old woman, you know, with a little cognitive decline, and she just couldn't spit the history out. And what was interesting is, once I knew the diagnosis and examined her by confrontation, man, did she have a field cut. And it was just funny because I totally blew this off on exam, on history, etc. So this patient actually had an occipital stroke, and it's one of those strokes that's easy to miss because they're not going to come in with a facial droop. They're not getting called as a code stroke. They're not looking like a classic stroke. Anyway, I blew this. In the fourth case, an 82-year-old male complaining of acute painless vision loss in his left eye, lasted for 20 minutes, okay? And described a gray shade in his visual field that took his vision away, and he couldn't even see light. And by the time I see him, everything's good. He's a diabetic with hypertension. on, arrival, he's a little hypertensive. He's got his bifocals with him and he sees pretty well with them, and he's got pretty much normal exams. So what do you call this? It's transient visual loss. People will use the term amaurosis fugax, but that's not exactly synonymous in the literature circle. So transient visual loss is to be considered something bad, okay, especially in the older patients, but it's not necessarily synonymous with amaurosis fugax, which has a thromboembolic implication. So you can still see this. Up to a third of patients with temporal arteritis will have this, okay? It'll go and come back. Amaurosis fugax is usually in situ thrombosis. Usually it's from a carotid source. It can be anything, north of the common carotid, but of course they got common carotid, they're going to come in with other stuff, right? But oftentimes these people have cholesterol emboli that, they'll occlude a branch retinal artery, or they'll have a central retinal artery occlusion, and then for some reason this thing breaks up and moves on, and it may only last a few minutes, but it has huge implications. Central retinal vein occlusion, you wouldn't think could come and go the vision, but it can. And ocular migraine. Does anybody want to diagnose a first-time ocular migraine in an 80-year-old man? No. Okay, so this guy had painless loss of vision. This is to be considered a retinal TIA with a retreatable vascular cause until proven otherwise. By any other name, it's a TIA. Think carotid disease, valvular heart disease, AFib. Okay, if they had what is known in the ophthalmology world as an altitudinal field cut, which means they lose the upper lower visual fields, or they have something called retinal claudication, which is interesting. I'd never heard of this term. They're looking, reading, they're using their eyes a lot. I don't know who doesn't use their eyes a lot, but they can get claudication. I've never heard that term. I thought I'd throw it in there. These are very suggestive of carotid stenosis. They need admission, vascular imaging, echo telemetry, SED rate if they're older than 55 years old, and even if they're men. Consider hypercoagulable workup. And again, if you think it could be a blood clot in the brain, you want to CTV, MRV these patients. If you ever see this, I've seen this once or twice. It's kind of fun, It's like an unknown flying object, right? The UFO or the retina. You're looking in this retina, and all of a sudden there's this bright thing out there, and you have no idea what it is. That can be a cholesterol emboli. If these are found by the internist, on a physical exam, they're usually benign. They still will get them worked up for carotid disease. So, this is sort of the equivalent of the, carotid bruit, just an ophthalmologic equivalent. But it's not usually an emergency. But I would say this: if you found this on a patient with acute symptoms, I would say that's pretty important, and that patient gets worked up quick.